Hello, everyone. So here's just a quick outline of the presentation that I wanted to give today. I'll just say straight away that I'm not using really sophisticated GIS methods. The more the focus of this talk is obtaining data where there was no data. So as we all know, if you don't have any data, you can't do any GIS or visualization. So that's really the focus of this talk. So I'll talk about how I did that. The other thing I'd like to highlight is something that Aaron said earlier today was we're really trying to work more with the community and push this information that we have here at the university out to the community. So this is just another example of how we're doing that, working with the city health department. So just a little bit of background here. Mayor Francis Slay of the St. Louis City Health Department, Mayor Francis Slay of St. Louis City identified a goal of reducing obesity in St. Louis by 5% by 2018. So a coalition was formed, and there's many partners on the coalition. WashU is one of the partners. Myself and a couple of other folks are part of the coalition. And it's called the Healthy Eating Active Living Coalition or Partnership. They didn't have any baseline data for the city. The BRFSS is a national survey, a phone survey that's self-report. However, they did not have enough respondents in the last few years from St. Louis City, and so they did not get any data basically for that survey. So that was kind of the big problem, is how were they going to assess the situation. So we started reading and doing some looking at the literature. It came up with some ideas from what other folks were doing, which we thought were pretty interesting. Mainly we were able to look into getting height and weight data from driver's license records from the Missouri Department of Motor Vehicles. And then I was also able to obtain a de-identified data set from BJC of heights and weights of patients. And we were able to obtain street addresses on all that data. Obviously the street addresses were identifiers, and I did not release that to the city, so I kept that in-house. And this is more for a national talk that I did last week, but I think it's always important. I go to a lot of GIS presentations, and I feel like people just start straight away with an image of their city, and if you're not from that city, then you have no idea what that means. So I always like to put a little bit of a description in there. And it's just a quick method slide showing how we work with the data. And I should have said this earlier, so I come from the Public Health Data and Training Center here at WashU, and so my focus here at WashU is working with data and data management, and this was a big data project in both the literal and metaphorical sense, I guess. They obtained over 400,000 driver's license records. We had, and I worked with, there's a GIS person at the St. Louis City Health Department, so we worked together. He geocoded those addresses. We eliminated records that didn't have heights and weights that made any sense. Ended up with 171 records. I should add that a lot of the records were either in the city or the county, and so we had to kind of eliminate ones that were split by a particular zip code. And then ultimately we calculated BMI from the heights and weights. These are just some of the results, looking at the age distribution across the driver's license records. Obviously starts at age 16 and goes up. I believe we capped the data at age 90, which still left majority of the folks in the data. We also looked at the age or the last point at which they renewed their driver's license. So we all know that people typically don't update their information when they go to renew their driver's license unless they've moved, because you're just trying to get through the DMV line as quickly as possible. So I had to take that into consideration. We looked at distribution by gender and BMI, and then also looking at regions of the state. One of the things that it's nice about this particular data set is that there's a wide distribution. It's not, so you're less likely to have selection bias, which is something that we're really concerned with in surveillance work. And these are just a couple of the maps that were generated. These first two are kind of your typical, looking at obesity. Darker blue is higher rates of obesity. Those of us who work in public health, you typically see the same areas of St. Louis City light up, whether you're talking about poverty, obesity, diabetes. So there's nothing really earth-shattering here. But we did also create some maps by neighborhood and by ward. So these maps are helpful in the city. A lot of people think about their neighborhood more than their zip code. So in terms of targeting future interventions, this is helpful. And in terms of talking to older people who represent each individual ward, we felt like displaying by ward was also helpful. And again, with the address data, we had this flexibility, whereas normally, even if we had obtained the data from the survey, we wouldn't be able to do anything with it below zip code. So typically when I talk about driver's license data, people roll their eyes and they say, oh, well, there's this and this and this problem with it. And yes, we agree. Fortunately, there is some literature on comparing the driver's license data with an individual's actual height and weight. And so as we can all imagine, people don't always tell the truth on their driver's license. However, fortunately, people generally don't tell the truth consistently in the same direction. That is, women typically underreport their weight and men typically overreport their height. And so you can adjust for that, and we did slightly in our data. We also noted that 85% of the data was multiples of 5, so clearly people were estimating. So we consider that a limitation. And then as I said earlier, the date that the information was last recorded, was typically variable. And so I remind my partners at the city, this is a cross-sectional data set. So while we didn't have any data before, we cannot really use this data to measure progress going forward, because the next time we get it, it'll be a different cross-section of the individuals. And so it would be hard to do that. And so I'll just switch quickly to the patient hospital records that I was able to obtain from Barnes-Jewish and St. Louis Children's Hospital. I obtained over 85,000 patients. I think I asked for the last couple of years. So it was a pretty robust data set as well. I have not had enough time at this point to really dive into it as much as I would like to. But as you can see, we had pretty good representation around the state. Again, the goal with surveillance work is to get as much data as you can and not limit it to any particular category so that we can generalize the information as much as possible. So patients were geocoded to census tract. I did obtain their street addresses. They are geocoded to census tract. We do have their ICD-9 codes or diagnosis codes. So potentially in the future, we can exclude folks who potentially had obesity-related diagnoses. However, there's pros and cons to that. If you exclude those folks, then your sample is no longer representative of the population. So we're not sure how we're going to treat that just yet. This is just a quick description of the patient data alone. When we classified BMI into the four CDC categories of underweight, normal, overweight, and obese, we found that men were more likely to be overweight, women were more likely to be obese, and actually that pattern held up in the DMV data as well. And this is, again, a map of St. Louis City showing the percent obese by each census tract. And the areas in darker colors are greater amounts of obesity. We do have some pockets in South City that weren't necessarily on the other map. So that was of interest to us, something that we noted. So in terms of conclusions and next steps, we have a lot of work to do. I'm currently in the process of trying to find some students to help us out with this data. This is just a lot to sift through. But the goal, again, was to obtain data and describe a topic and a space where we had no data, and we were successful in that regard. I've since gone back to the state and asked for the entire state. So originally we just got St. Louis City, and that was, like I said, about 175 clean records. I now have a little over 4.5 million records from the state, and I have street addresses. So we're going to be trying to map and depict obesity rates across the state of Missouri with that data. And so as you can imagine, we have a lot more statistical power with higher numbers. We also plan to integrate other GIS data sources, so parks, transportation, into this data set. Also, other census data we'd like to integrate into this data set to look at factors that we know are associated with obesity. And one thing that I struggled with, and I'm open to input on, is how to compare the different data sources. So I'd like to validate the different data sources. We have one from the DMV that was self-report. We have another one that's patient data that was presumably measured heights and weights because they were going to the doctor or the hospital. I'd like to think about how I can compare the two data sources and see if they can validate each other, so that we can eliminate some of the limitations of each data set alone. So that's something to think about going forward. And then just some lessons learned. So a lot of what I do at the data center is we get data from places that people think I won't be able to get data from. So I guess the way that I would put it is be creative. So if you have a problem and you don't have data, you're not happy with the data that you have available, try to think about other locations that you could get this information. A lot of non-data people that I talk to, when they find out what I do for a living, they want to talk about technology and servers, and I quickly remind them that getting data, especially the type of data that we get, is really more about relationships and trust building. Getting someone at the government or at a hospital to share their data with you won't happen if they don't trust you, if they don't think that you have the best goal in mind for the data, the best motives, I guess. I think the last tip I would add is talking to the right people. So a lot of times when I'm asking for data at a particular location, I get sent to the CEO or I get sent to somebody that really has no idea about the data infrastructure within that agency or that institution. So it's generally a combination of talking to the actual data analysts, the data folks, to see what's available, but then you have to go back to the authority at the institution to get the permission to get the data. So it's definitely a trust building, and like I said, it's talking to the right people is really important. That's all I have. Thank you.